Hi, everybody. So now that I have talked to you about being a nurse, I thought it might be fun to give you a virtual tour of our trauma room and talk to you about what happens in here. I will kind of walk you through our assessment of a patient and describe the different equipment we might use depending on the condition. From here on out, you will primarily just hear my voice as I show you all the equipment and describe its use. All right, so welcome to our trauma room here at KU. As you can see, here's one bed and here's my other bed. So our trauma room, we can do 2 traumas at the same time. Gets to be a very crowded place. It's crowded with 1, but you add 2 and it is really kind of crazy and chaotic. As we come around the side here, we've got a desk. Each bed has its own separate desk. And this is the scribe's desk, or the person who writes down everything that's going on. From IVs being started, medications given, catheters put in, physician assessment, all that stuff. We write that down. At this point, that doesn't go on the computer until later. We're still paper charting for this, but this is one of the few entities in a hospital that still has paper charting. Everything went to computerized, I'd say about 4 years ago or so. And it's actually mandated by federal law. So anyways, when a person comes in, and here is my dummy on the bed, we are looking at them and assessing them from the second that they roll in with the ambulance or on the ambulance cart. We're looking at whether or not they're talking to us. If they're talking, they're breathing. Obviously, breathing is a good thing. If they're unconscious, we're going to get a tube or a breathing tube in them pretty quickly, because you're not going to maintain your airway unconscious for very long, typically. We look at what the skin color of their skin, not just black or white, but whether their skin is pale, almost whitish, or a dusky gray or mottled color, blue, kind of a blue undertone. Those are not good colors. Kind of gives us an indication that we have to move very, very quickly to determine this patient's injuries. After we get them transferred over to our cart, we get patients hooked up. So they're put on a heart monitor. That would be the stickers and the colored things that are on this guy's chest. And we want to look at the heart rate and his vital signs. We're going to take a blood pressure. Ooh, my camera's kind of getting fuzzy. We're going to take a blood pressure. We're going to check and see how fast his heart rate is beating. We're going to take a look at how well his oxygen levels are. And I'll show you here in just a second. I'll pan up to the monitor and you can see what a normal heart rate looks like. All right, you guys, so when a trauma comes in, we get them hooked up to the monitor. It's what our tech does. It's one of the first things that he's going to work on. As you can see, we've got a heart rate there in green. The more I talk, the faster my heart rate is going. So I would be considered sinus tach right now, meaning tachycardic heart, which is any heart rate that's over 100. I've seen heart rates as high as 210. I've seen a heart rate as low as 32. Neither one of those are very good. It just means that your heart is not going to be pumping blood very well through your body, for all of your tissues to get oxygen. The blue line there, 96%, that's how well I'm oxygenating in my blood. So anything above 92 is good. If you're a trauma, you got to be 94, just because your tissues are more taxed and they need more oxygen. The purple number down there would be my blood pressure, and the white line says that I'm breathing 10 to 11 times per minute. Besides the sinus rhythm and the sinus tach that I kind of told you about, we have other rhythms that aren't really good. Sometimes we can induce it with just artifact movement of the leads and stuff. This would be a very bad rhythm. This is called V-tach. Means your heart's not pumping out blood, which means your body is not getting oxygen, which is not good. You won't live very long with a rhythm like that. Panning back to my patient here, if you'll notice, he's got a collar on his neck. That is to keep the cervical neck, or your cervical spine or your neck immobilized so it's not moving. Lots of times if you're in an accident of any sort, we're going to put one of these on you until we can rule out that you do not have a neck injury. Any fracture of those bones there in the back of your neck, if you move the wrong way and you already have a fracture, it can completely fracture it and pierce your spinal column, and then you're paralyzed, which means you won't be able to move your arms and or your legs depending on how high or how low in your neck that injury is. All right, now as I mentioned, when patients come in, we kind of we are evaluating in a specific order. Again, we talked about the consciousness. We talked about if they're conscious and they're talking to you, then they're breathing. But sometimes people are having a hard time breathing. Sometimes they just need something simple like this, which is called a nasal cannula. It's just a couple of prongs that go inside the holes of your nose there, inside your nares, and it just gives a little extra oxygen to a patient. Sometimes if a patient is hyperventilating, meaning breathing really fast and really shallow, we'll have to put something on called a non-rebreather, which would be this mask here. It fills up with air. You get air through the mask, and then you're rebreathing the carbon dioxide that you're breathing off really, really fast. So if anyone has hyperventilated before, you probably got very dizzy, and that's because you're blowing off a lot of CO2 or carbon dioxide. It collects in that bag, and then as they breathe back in, they're breathing back in some of that CO2 to help stabilize them. Patients can be not talking to us, unconscious, but breathing on their own to have this, or awake, either one. If someone is unconscious, we are probably going to, and not protecting their airway, we're going to use this thing here. It's called a bag valve mask. So as you can see, it's got a mask on it, and there is a bag here. So we would put it over the nose. See if I can do this by myself. We put this over the nose and over the mouth, push it down real tight, make a seal so that it's covering everything, and then squeeze the bag to give oxygen. We will use that bag valve mask that you saw as we're getting ready to intubate a patient. If someone can't protect their airway, they're going to get a tube that goes in their mouth, down their throat, and into their lungs, and hooked up to a machine that will do the breathing for them. Let me show you what that. All right, so this is the model of someone's mouth. As you can see, the teeth and the tongue, and if you look real close, you can see two separate holes. The one in front has a little flap. That would be your airway or your trachea. The one in the back would be your esophagus, or the tube that goes down to your stomach. So when we intubate someone, we're going to put a tube down that first hole that's going to go down into their lungs. The flap there is actually what closes over your trachea every time you swallow, so that food and saliva and your drink goes down into your esophagus, or that back tube, instead of into your lungs, which if any of you have kind of swallowed wrong and gotten something in your lungs, you know it tickles, hurts, takes your breath away. So we want to make sure that we get stuff in the right spot. But again, if you can't protect your airway, if you can't breathe on your own, you're going to get a tube in that front hole right there that's going to go all the way down into your lungs. All right, so next up is the circulatory system, looking at your heart and your blood pressure. So if someone is bleeding a whole bunch, then they're going to have a really high heart rate and a really low blood pressure. Some people, not every trauma that comes in is what we call unstable, meaning having that huge difference, having a high, very fast heart rate and low blood pressure. Some people are stable. Their vital signs are still regular. In that case, someone would be on just regular IV fluids, maybe just kind of free flowing, and just regular tubing like this here. If someone is bleeding, losing a lot of blood internally or externally, we're going to use something called a rapid infuser. And it's going to be this big tubing here. So you've got this bag of, actually you'll have a couple of bags of fluid. You can have up to 3, 1, 2, 3 going in all at one time. Pumps into this huge chamber down here. And just to give you an example, so in size, whoops, can't quite get it there. There we go. So we have the rapid infuser on the left and just regular IV tubing on the right. You guys can see what a huge difference that is. The rapid infuser, we can put a liter of fluids, which would be this big bag here, infuse it in someone in about 5 minutes. It's also very much used for giving blood, because if someone's bleeding really fast, we need them to get blood really fast. While fluids are great to kind of keep the circulatory system up and keeping pressure, running through the veins and the arteries. Blood is more important because it actually delivers the oxygen to the cells. Without oxygen to cells and throughout your body, tissue starts dying. So traumas, we will use this device here to rapidly infuse a whole bunch of fluids and blood product. Next, when talking about your cardiovascular system, if someone's heart rate isn't normal, then we're going to use something called a code cart. As you can see, this is labeled airway. You've got everything that we need for code, meaning somebody's heart is not beating right. Sometimes they don't have a heartbeat. Sometimes they don't. The heart is still beating, but they do not have a pulse. Sometimes their heart is just beating so erratically that the heart can't pump properly. So this cart here has all the medications that we would use to help get that heart back into a regular rhythm. There's a separate monitor, so the patient will be on 2 monitors at the same time. I said all of our everything that we need is in there. We have another one over here, and this is actually, if you notice, it's color coded. This is a pediatric cart, so it's all weight based. So every drawer has everything that we would need for a child that size. Our weight is based in kilograms here in the medical world, which that would, if you multiply the kilogram weight by 2.2, that would give you the amount of pounds. So approximately a 9-kilo patient is going to be about a 20-pound patient. So I said everything is, the pediatric cart is really nice because all of our medications are already dosed based on the child's weight. Another part of the cardiovascular is making sure that we have the right size of IV that we need to get medications and fluids into you in proper time. So you can have a peripheral IV, which I'll pass around a sheet that has all the different sizes that we use. This is called a triple lumen, so it's going to go in your neck or right underneath your collarbone. And that catheter feeds through your veins and sits right above your heart. So we have 3 different ports here that we can infuse medications through because not all medications are compatible or can be infused together, can be mixed together in a line. Allows us to draw blood from it. We also have a cordis or an introducer, which, as you can see, the size difference, this is relatively small. This is getting quite a bit bigger. Not fun to have to put that in if you are awake. As you can see, the tubing here is also a lot thicker than this tubing over here. This is pretty thin. This is very, very thick. Again, this is so we can get massive amounts of fluids and blood through a person without any difficulty. And then we have something that's even slightly larger, and this is called a MAC. So you have multiple ports for doing IV blood draws and different medications. Quite often you'll have this MAC, and then the triple lumen actually feeds through the top here. So you have an IV inside of an IV. So you have 1, 2, 3, 4, 5 ports all at once for giving lots of medications. These people are very, very sick. Sometimes they don't make it, and sometimes they do. All right, so while we've got the assessment going on and IVs being started and someone being intubated, you've got someone who's coming at you with an ultrasound machine. So ultrasound or sonogram, it allows us to see your organs inside, allows us to see if there's any blood collection. We will look at a patient in 5 different places. We'll look around your heart. We'll look in your lungs, both sides. We'll look over your liver, which is right underneath your right ribs. We'll look at your spleen and your pancreas, which is underneath your left ribs. Those are all places that tend to start bleeding in a tragic situation. So that is one of our other things that we use here in the emergency or in the trauma room. All right, next would be talking about kind of your GI system or gastrointestinal digestive system. So if someone has vomited, we're going to have to use suction, which are these canisters here. Sometimes people take stuff if they're unconscious and they vomit. Sometimes they get that down in their lungs, and we have to suction that out of their lungs. If you don't, they get very, very sick and develop a horrible case of pneumonia. So I said that stuff has to come out. Those people are going to be on a ventilator, and so we can suction through the ventilator tubing. If someone's body temperature is really low, we're going to put them on something called a bear hugger to warm them up. It's got a blanket that goes over the patient, and then this tubing here connects to the blanket, and it sends super, super warm air to the patient to help warm their body temperature. On the flip side, if someone is hot, we might put them on an Arctic sun, which can cool the patient's body temperature down. We can also do that therapeutically, meaning patient's body temperature is normal and we want to cool them down. If a patient has had a massive heart attack, we will actually cool their body temperature down considerably and leave it there for 1 to 2 days, depending on the damage to their heart, because it actually allows the body to rest and your heart's not working as hard, so it helps it to recuperate. So next up, I bribed a few of my coworkers into doing a little trauma skit for you. Thank goodness for extra Girl Scout cookies. What you are about to see is not real. No one was harmed in the making of this video.
Oh no, I've been shot. I'm bleeding through my shirt. It's all red.
Let me get him up on the bed.
Oh, great. Thanks. All right. Sir?
Hi, that
You're on the
hurts.
monitor.
Okay.
His airway is Peyton Savoy.
Peyton DuBois. Do we have allergies to any medications?
Haldol, Ativan, epinephrine, propofol.
Take some deep breaths for me. All right. 16 gauge in.
16 gauge in.
Right cheek. Here's bilateral breath down.
Getting a pressure.
Would you like me to activate the surgery emergency team?
Perfect. Yes, please.
Please activate
Yes,
the surgery
bilateral
emergency team.
breath.
Where are these?
Are
you- what am I doing?
We have the helicopter coming in. It'll be in 15 minutes.
Great.
Roger.
Give me a report from where we get
Ow.
shot. Breath him in.
Yes, this patient presented to the triage. He said he was shot in the chest 20 times by his 12 gauge shotgun, self-inflicted. He drove himself here. I think ETOH on board. He says his cousin's a doctor, so he knows everything about what should go on
Would you
here.
like a chaplain?
Yeah, call the chaplain. Where's RT at? Where's
Come on, take
RT?
those shoes off.
Sir, can you squeeze my fingers?
Squeeze,
Okay, with your other hand too.
squeeze.
Good, and push your feet up against my hand. Good. His GCS is 15.
15 GCS.
Yeah, fabulous. Let's get him exposed.
All right, let's get his clothes off.
Great, hang in there.
I'm going to order some blood.
Great, thank you.
All right.
Is the blood drawn?
Let's do blood's drawn.
Okay.
A quick cooking.
Officer Lopez.
Yeah.
Yes. Let's preserve
We'll see
his.
if he has any bleeding.
Officer Lopez.
Perfect.
Yes.
We need to preserve some evidence of bleeding on his hands, please.
Ouch.
In case he has anything
You're
underneath
doing
his
great.
fingernail.
Hang in
I
there.
don't like being shot.
Do
Please.
you want me to call your mom?
Yes.
There you go.
Okay, she's here.
Good. She never leaves this
She
place.
never leaves this place.
Why is there?
I don't know.
Oh, yes. We need another bag over here. And we need his.
Officer Lopez.
Yes.
I believe I see some secondary trace information on your socks.
Don't
Okay.
move.
Fast scan is positive.
Fast sand is positive.
All right.
We'll need him to go to the
Turn.
OR. We
Okay.
have 2
You
large
want to turn it?
varieties.
You want to turn towards me and check right into him?
I got him.
Remember, it's girl. Remember who we're.
Alright.
This thing is.
Did they get this hurt?
No.
No, no.
Here, here,
No, no.
We're gonna defer.
Any abrasions? No cuts.
Good.
All right. We have the hemoglobin behind you, doctor. If you want to get a card.
No, I think we're gonna defer that. Give him-
Okay.
All
Roll
right.
him back. Okay.
Ow, we lost our evidence collection bag. Oh man.
Great.
Not that I feel.
Are you on any medication?
No,
Allergic to anything?
I believe we should just
No.
take him to the OR,
Let's do
doctor.
it.
no.
All right, get him on
Losing
oxygen.
consciousness.
Let's take him to the OR.
All right, Officer
BVM.
Lopez, could you take him to the OR, please?
Are you still awake?
Yeah.
All right.
Okay, let's get him out of here.
Let's go.
To the CT scan. Or are we going straight
No,
to
we're
the
going
OR?
to the OR.
Oh, my bad.
You are.
Let's go.
Oh, wait. What is on me? Bob is on me.
Bob's on there.
Exit 10. Wait, an exit